This non-promotional podcast series is organised and funded by UCB, intended for healthcare professionals in the UK and Ireland.
Welcome to the Let's Talk About Dravet Syndrome podcast series. I'm your host, Micheal Taylor. I'm a consultant paediatric neurologist in Leeds Children's Hospital. In this series, we'll share practical input from specialists and real-life stories from patients and their families. This is to bring you closer to this topic, raise awareness, and empower the medical community to work closely with patients and their families to improve outcomes and quality of life. If you've not done so, please hit the subscribe button so you don't miss another episode. And if you love this podcast series, please do me a favor, give us a rating or review on whatever platform you're listening to us on. The reason we need this is the more positive reviews or ratings we get on those platforms, the more this podcast will be shown to those who have never listened to us before. The aim is to improve the lives of people who have Dravet Syndrome.
So welcome back to another episode of Let's Talk About Dravet. And today I've got two guests. This is truly a true international episode. It's 10 o'clock in the UK. I am in my very cold office in Leeds Children's Hospital. And we have, all the way from Texas, Dr. Scott Perry, who is the head of neurosciences and director of the Jane and John Justin Institute for Mind Health at Cook's Children's Center, Fort Worth, Texas. And we have in Sydney, so other side of the world, we have Professor Ingrid Scheffer, Chair of Pediatric Neurology at the University of Melbourne and Senior Principal Research Fellow at the Laureate Institute of Neuroscience and Mental Health. So two of the people I regard as the absolute giants in pediatric epilepsy. And it's really brilliant to have you both here to talk about really how can we do the best for our patients. For me, the very first thing I want to talk about is diagnosis, because I think it's a big delay. I know certainly in the UK, what our charitable, our UK charity, Dravet UK, frequently feedback to us as clinicians is, there's always that delay. Do you think that translates into what you find through, in the States and in Australia?
I'll say in the States, yes, there's always, still some delay, right? There's enough for me. But it has improved significantly, honestly. I think through like some of the work of the Dravet Syndrome Foundation, for example, and getting people more aware of what Dravet syndrome looks like, really raising the level of alert for people to think about it. I think, fortunately, we've had some programs where genetic testing has become more accessible in the U.S. So a lot of kids who present with a kind of a first unprovoked seizure have access to testing, whereas we didn't have that a decade ago. So that's really, those things have been helpful. Do I still see people that were not diagnosed in a timely manner? Absolutely. And of course, always remind people that there's a lot of adults out there walking around with Dravet syndrome who never had the opportunity to get tested as children. The drug-resistant epilepsy without etiology, to at least be considering a genetic etiology of which Dravet might be one.
Definitely. And I think actually for me, this comes down to recognizing that there's this expanding phenotype. And I know that I have veteran colleagues in the UK who still sort of think of that original phenotype described by Charlotte Dravet many years ago. And they always seem surprised when I talk about the expanding phenotype that actually, it's not just that small cohort of children who present with a prolonged hemiclonic seizure in the post-vaccine era. Actually, most of the kids present with actually under 5 minutes generalized tonic-clonic seizures. I think that's really, really surprising. So do you think that is going to help with diagnosis, or at least people thinking a little bit more readily about Dravet?
Look, I'm excited to hear, Michael, that you're giving a diagnostic algorithm to so many of the clinicians that you're interacting with. The aim of this in the lead paper is to help facilitate early diagnosis. So from the very get-go, you see a baby at 6 months come in with a 5 or 10-minute seizure and you go, could this be Dravet syndrome? One of the other points we emphasised was the duration between the next seizure. And people tend to think it should be a month later, which is sort of where it averages. But in reality, some babies might not come in for 6 months with their next seizure. So you really have to have a high level of vigilance to consider Dravet as early as possible, recognising not all babies are triggered by fever, most, but not all, and that often the first seizure may be afebrile. And the reason for early diagnosis is that we can then manage the patient quite aggressively, try and fully control seizures to try and improve long-term outcome.
And I think that works really hand in hand with this work being done by Professor Brunkhaus out in Glasgow. With the, when we've identified that SCM1A mutation, we now have the ability to put them through the modeler. Obviously, it's not perfect. I have patients who you put them in the modeler, they're 95% chance of having Dravet syndrome, and they're a barn door guess plus. So it is, but I think in combination, we're now able to open up that cohort and think about bespoke treatments, think about drugs that are used in Dravet, and more importantly, as we're going into that advent of gene therapy, we're going to need to consider the earlier diagnosis, because hopefully that will translate, rather like in the SMA population, earlier treatment, better outcome. There are different guidelines. Certainly, where drugs fall on the guidelines in the UK and US, there's very subtle differences. Do you think that these make huge differences, or do you think that actually we have very similar approach not internationally to Dravet? Do you think there is a way that we could get to an international consensus guideline about how every country approaches, or do you think that we all have our little quirks and eccentricities? For example, in the UK, we have NICE, who very much give us guidance.
I would say that there are some differences, but whether or not those differences are hugely important. I mean, the real key is that people recognize the drugs not to use and recognize the drugs to use, whether that particular order is better or not in one place or the other, as long as we're using the right drugs. I think there's always probably going to be some amount of differences just by the environment that you're practicing in and what is available and how easily it is to acquire it. And honestly, like I said, that's what's important, is that you're using the right drugs. And if you've got a class of right drugs and one is more available to you than another, then great, that's the drug we use. I don't think that it's...
Absolutely agree, and I think we have to be really clear that we are talking sodium channel blockers here, that we know they are associated with harm. We know that they have long-term implications, even long after they have been stopped. And the longer they are in use, the longer they cause harm. They're great for different epilepsies, but not in Dravet.
Correct, exactly.
I don't think all sodium channel blockers are equal. The thinking about sodium channel blockers needs to be nuanced.
I think that's something that hopefully with Andreas Brunkhaus's Horizon study and the natural history studies that will sort of come through, is actually in that emergency situation, it's a useful set of drugs. And I know, having spoken with Scott, he was saying some of his patients, or some of the patients that they have, it gets put on care plans as allergy to try and stop people using it. But we both were in agreement that actually it's still a useful drug.
We do need to have guidelines. However, neurologists tend to be a little bit cautious, I guess, in their approach. And I think if the child has Dravet syndrome, one should be going for the drugs as early as possible to produce seizure freedom, and not walk through 4 or 5 drugs in a row whilst you get to the better drugs.
And I think this is where age of initiation of some therapies is over the age of 2. However, I know that also a lot of the pharmacological companies are looking at expanding their research and trials into the under 2s, and I think that will bear out in time. What would you say is the challenge about getting the children to somebody who has an experience of Dravet syndrome? Do you find that there's holdups? We've got a really great network in Yorkshire. Actually, one of the things I've been able to do is with my genetics lab is as soon as an SCMI mutation turns up, it pops into my inbox, so I know about it.
Well, that sounds fantastic, but I do think we need to have experts that are available to consult on these patients, but we have to start in the emergency department so that the general paediatrician actually thinks about it from the first seizure in the right age infant. And that requires ongoing education and reminding and making sure that genetic testing is offered earlier, as you said, ideally after the first or second seizure, so that that diagnosis the gene testing will pop into your inbox.
In the UK, we have access to rapid gene sequencing on the under 1s. So that's been really, really good for epilepsy. It's starting under 1. Do you think, how does that bear out with Australia and the US?
Yeah, so as I mentioned earlier, in the U.S., we're fortunate to have some sponsored programs that actually allow testing to be at least provided with easier access earlier in life, which the importance of getting the test, that's great. So to understand that the variant present does or does not reflect a diagnosis of Dravet syndrome, or if you're not sure, just making sure, as you mentioned earlier, getting them to the right place. It's so important to make that connection, if not to the physician, to the advocacy group for the condition, which can also often help the families get to the people who are knowledgeable about the disease to inform them on best treatments and kind of create that care plan.
From the Australian perspective, access to molecular testing early in life has been difficult, but is improving. I do think there's also an issue, though, about what you were referring to before, the distinction between GEFS plus and Dravet syndrome. And I feel that sometimes clinicians are scared to make a diagnosis of Dravet syndrome, and really the writing is on the wall, and the diagnosis could be made earlier if they understood the phenotypic spectrum a little more clearly.
I think that comes back to your paper, and when I see a new patient, I have the paper beside me. Can they fit in? And actually, one of the things I really found very interesting in your paper was about that small cohort, that 1%. I remember you having a very spirited debate with Samir Zaveri at Dravet UK about that 1%. And actually, what was really interesting was the Swedish paper came out about a year and a half ago. Very similar, that 1% with a relatively normal IQ. And then, lo and behold, I had a patient who turned up in clinic, and I was actually, I had to go and get neuropsychology testing. He was just on the borderline. And that for me was really difficult, because actually, did I have one of that magical 1%? But actually, it was really did a deep dive neuropsychology to really pull out any learning issues. So I think if you're not thinking about that part of your phenotype, you might miss the patient who they're just a bad GEFS plus. Oh, but they're developmentally normal.
Yeah, I think that can be tricky, because sometimes their developmental impairment doesn't come out until later. So, for example, I saw a 28-year-old last week who has moderate intellectual disability. But when I met her at the age of 6, I vividly remember that she was of normal intellect. So her development fell off much later. The other key issue in this situation, of course, is the risk to their offspring. So they'll have a 50% chance of passing on that SCN1A pathogenic variant, and therefore their child has a serious risk of Dravet syndrome.
I think the other important thing, just to think about this, especially when you're talking about a very young child who's coming in with this SCN1A variant, and you're trying to maybe make the diagnosis or differentiate between, a GEFS plus or a Dravet syndrome. I often tell families when I see them, and maybe the child's only had a couple seizures that are otherwise developmentally normal, I may not be ready to end on the exact diagnostic syndrome just yet, but does it really matter right this second? Because it's an SCN1A related epilepsy. And so I need to treat it as such. And again, avoid daily maintenance medications that we know are not the right types of medicines to use, and to use the right ones, and to make sure that I'm giving them a good seizure action plan so they know what to do when these seizures occur again. And then, of course, the genetic counseling aspects that Ingrid mentioned are important as well to discuss. But just understanding that you're dealing with a condition where the SCN1A variant is likely the etiology, and treating it as such, whether it's time to call it Dravet syndrome or not.
I think that is key. And also it goes down to something that Ingrid has said as well. We want to treat this aggressively. Do we know what that aggressive treatment is going to do to the natural history? It's one of the things I frequently ask Andreas about. What if we had done the natural history study 20 years ago? Is it going to be very different to the natural history study today with our knowledge? I imagine yes. I imagine we are not going to have most of those kids going through.
Yeah, sorry, Michael. There's already good data to show that's the case from the French. Ragona with Charlotte Dravet, and they showed that with the introduction of more appropriate anti-seizure medicines for Dravet syndrome, the outcomes were better. So I think we know that, and I think that's also an important reason to understand when you're dealing with Dravet rather than GEFS plus. And even last week I saw a 22-month-old baby who came from Sydney to see me in Melbourne, and the pediatric neurologist had just said, oh, well, I'm not sure. And I looked at the pattern of, they're only having tonic-clonic seizures, but the pattern was clearly Dravet. They were longer, 5 to 15 minutes. There was only one episode of status. Some were with fever, some without. But the patient is only 22 months, development's completely normal, but clearly is a Dravet pattern. And that's why understanding that phenotype is all important.
Absolutely agree. I think, again, as I said, I have your paper on standby every time I have the gene. Every time. And it's just about showing that pattern, and it's about making sure, does it fit? Does this child go into the phenotype that we expect? Do you find that having specific clinics to deal with these patients keep you minded to pick them up a little bit easier whenever you're seeing the patterns, recognizing them? Or do you find that being a good epileptologist means that you're going to recognize them irrespective?
I'll say this. I think having the clinics that specialize in the condition are important for the reasons of educating the families, potentially more completely about the disorder, right? Specifically about allowing them to know what options are out there beyond the things that are out there and approved, right? We also generally are participating in lots of different research trials and things of that nature. So we're able to offer a wider spectrum of potential options. We have, of course, the experience of seeing lots and lots of children with the condition, so can offer, potentially a more well-rounded understanding of the prognosis and the variety of, paths that it can take over time, and connect them also with the the other services that they may need, because it's not just seizures. Dravet syndrome comes with a variety of other comorbid conditions that need to be addressed. And so often these clinics will have those other specialty providers available, to help with the things like the sleep and the behavior and the abnormal gait and those kinds of things. Obviously, I think just being a good epileptologist is important, and any epileptologist can make this diagnosis, and any epileptologist can exercise the correct treatments using the consensus guidelines. But there are some advantages to the clinics that have specific expertise in the condition.
Yeah, and if I can add to that, I think all pediatric neurologists should have their eye in for Dravet syndrome and think about it. And if you have a baby presenting with a hemiclonic seizure, the first thing you should think is it Dravet or is it structural? And obviously you'll get an MRI. And if they present with a hemiclonic seizure on the other side the next time, then you should really be thinking, is this Dravet? And you should be asking the geneticist to look very hard at SCN1A. The other major benefit of having specialised clinics is the families support each other, and the family support organisations are just fantastic, like Dravet Syndrome UK and the Dravet Syndrome Foundation in the US. But on the other hand, when I've run a Dravet clinic for about 25 years, and the other aspect is it's a little confronting if they sit there and they know everyone's got Dravet syndrome and you've got this perfect little 2-year-old, and then they see these very disabled, I see adults as well. That's a little bit confronting if you think, oh, my child could end up looking like that. But, I think one of the aspects of our research studies is that the phenotype is much broader, and therefore I always start off with, this is a good thing. We know you can be much milder, you can have normal intellect, but you can still have life-threatening seizures even with normal intellect, and this predilection to status epilepticus, which of course is dangerous. So it's a matter of having that balance correct. And I do think specialised clinics offer another level of expertise.
I think it's something certainly that my patients, when they've attended things like Dravet UK, we have a weekend away where my patients come back and actually they find that really reassuring. They've seen this is where things could go wrong, but actually they've seen relatively much more able children than what the books tell them, what they've read online. They've been able to engage and say, actually, this much more capable person reminds me of my 6-year-old. Actually, I could see my 6-year-old ending up like this person I've met, this lovely teenager, or this lovely adult. So actually, I think that's where the charitable organizations, the family organizations have done so much work and been tireless advocates, both educating us as professionals, but educating other families and allowing them to see that things are not quite black and white. And there are, with Dravet, and certainly SCN1A mediated epilepsy, a real deep shade of grey.
Yeah, I think we need to be a bit cautious too about the gain of function SCN1A pathogenic variants, which end up with a much more profound phenotype with it usually begins in early infancy by 3 months of age. They can have hemiclonic seizures. They often have epileptic spasms, but those children are profoundly impaired. So it's very important families know this is a different SCN1A syndrome and not Dravet, because that's a bit scary.
And more importantly, we know that the gain of function SCN1A variants, in theory, should do respond a bit better to the sodium channel blockers, so that it actually completely changes your drug phenotype, and you may be putting them on you may be avoiding with good reason. You think that you're avoiding a drug that might harm the child, but actually could be a treatment option.
Right.
Yes.
Right. So I want to go back just really quickly just to talk about the specialized centers again, and just harp on the point that the specialized centers are important and we need them, but the specialized centers can't be the only member of the team, right? So the general neurologist or the epileptologist in the local area of the patient is incredibly important. It is very important to have a care team close to home, because when status occurs, when hospitalization occurs, it's likely going to occur locally. They're not always going to end up, here. So, for me here in Texas, or the state where it may take 8 hours to get across the state to get to my center, it is important that I maintain a good relationship with the neurologist locally who are going to care for that child and, remain available as their consultant to help them manage the children.
Absolutely would agree. And in Yorkshire, I have a great network of pediatricians with an expertise in epilepsy. And more importantly, actually, I think I have a really great network of pediatricians who don't have an interest in epilepsy, who are very good. And some of them are very much attuned to, hey, I've got a kid, they've got a load of seizures. Do I need to get some genetics? Because I think actually my general pediatricians are much more attuned, they really want to get genetics going because they are thinking, hey, if this is Dravet, there's a treatment. There's treatments that we can be using, or maybe some of my pediatricians with an expertise in epilepsy are looking now at, well, if I had this gene, I would use this drug, and it's just amazing to see my colleagues upskilling and keeping abreast of things that I'm just going. Maybe 10 years ago, we're only in the remit of a neurologist. So parents and caregivers are always, they need to be aware of the other services. What practical advice do you give parents about other things that they need to be aware of outside of epilepsy? What things do you think they should know? What things do you think they don't quite need to know straight away? And when do you want to breach those subjects?
Well, that's a really important question. I think even within the epilepsy, and I appreciate you just asked, outside the epilepsy, they need to really understand about monitoring the child overnight. I think that's important because of the SUDEP risks, sudden unexpected death in epilepsy, and the high mortality risk. So from the very get-go, I talk about mortality and I explain that it's well established that Dravet syndrome has a 17% mortality by 20 years of age through many different studies. And the biggest risk of mortality is sudden unexpected death in epilepsy. And I explain that's where the child dies in their sleep. And we think it's seizure-related. It can also be due to status epilepticus causing brain swelling, or to accidental cause or pneumonia sometimes, but that would be less common. And I think that's incredibly important. And in Australia, we would recommend they have a camera, like a SAMI camera is one example, and often an oximeter as well to monitor them overnight. So that's sort of seizure related, but then other morbidities one needs to think about. Sleep, as we found, occurred sleep problems in 70% of patients with Dravet syndrome. And if the child doesn't sleep and the parents don't sleep, nobody copes. So it's really important, sleep. The gait we described back in about 2011 about how you get a crouch gait. Initially, I thought it was more in adolescents, but sometimes you see it in little ones, and you need to get physios involved and try and use strategies to try and minimize that. Behaviour can be a huge issue, but only for some, and for plenty they don't have behavioural issues. Feeding problems can be big, and gastrointestinal problems. And we're now looking at a cohort of adults, of a rare proportion who get psychosis. So I think it's as broad as you can possibly imagine the comorbidities. And then we have to think about looking after families. But I don't want to hog the airtime, so I'll let Scott say something too.
All good things, and all things that I cover too. I think, anytime I'm seeing families, after I've gone over all those things, obviously it's quite overwhelming, right, to go over that wide spectrum and all of these comorbid conditions and things that can occur. As I alluded to earlier, I think it's incredibly important to link them up to their community, so to link them up to whatever the advocacy organization is for their area. Our clinics have large populations of children with these conditions, and these families connect with each other and find, their support systems, which I think goes back to caring for the family, because it's not just about the patient. You want to make sure that, the parents and the other siblings are heard, are making sure they're taking care of themselves so that they can take care of their loved one with Dravet syndrome, and just making sure that they have those educational resources available to them, and they know how to access them. Those are all important things. The other very important thing that I think we've talked about a little bit during this time that they must have when they leave that clinic is the seizure action plan. It is essential that everybody with Dravet syndrome, and frankly essential that everyone with seizures in general, have some kind of seizure action plan and know what to do in case of an emergency. But when you're dealing with a condition that everyone might not be familiar with, especially some of the first line people that may have contact with the patient, like EMS, emergency medical services, then you want to have a seizure action plan that outlines briefly what the condition is, its propensity to go into status, and its need for aggressive therapy to stop that. And then providing those steps of that aggressive therapy is a real key thing.
Absolutely. I think these are really things that we try to cover. And I know families sometimes need to have things repeated 2-3 times because you're delivering a big diagnosis. We want to impart all of our knowledge, all of our concerns, make sure the family is walking out well armed. But actually, sometimes that just takes a bit of time to get each of those things across. And then eventually, things move the other way. They become the expert and they're coming in telling you things. And you're going, okay, I'm going to learn a few things from you. And I always find that's one of the more rewarding moments was whenever the family comes in and goes, actually, do you know this? Yes. A humbling moment, but it's always great to learn from my families. I think it's really important.
So true.
One of the big areas that Scott touched upon was about the impact on the parents, but he also mentioned siblings. So I'm always very clear. My brother has severe autism, epilepsy, didn't sleep. I didn't know what a full night's sleep was until I went to university. At 18, I shouldn't have been discovering that. But it's really important to say that the impact on siblings is huge whenever you've got any of the developmental and epileptic encephalopathies. We know 42% of siblings have anxiety that requires treatment in adulthood. And that subsequently will have an impact on their children. So I always think about the developmental and epileptic encephalopathies, of which Dravet is one of many, having that direct impact on the next generation, albeit in very different ways, if not genetically. Do you think that we do enough as clinicians to look at the sibling groups?
My view is that we don't look after the whole family well enough, to be honest. It's not just the parents, it's the grandparents. They're often devastated. It's the whole, the sort of ramifications for the whole family, including the siblings. Like you, I had a disabled brother who died at the age of 20 and I was 18 and I have no other siblings. So I certainly lived that journey. And he didn't have epilepsy, but he was quite disabled. So it does have huge impacts. I think it's made me a better clinician, and I likely you too, because you understand the family's side a bit more, because you've sort of lived it. You spent the hours in the hospital or whatever that you had to do as a sibling. So I think it gives you another level of understanding. But should we be looking after the siblings? Yes, but I think if we look after the parents better, and we don't do that well, then that will flow on. Because if you've got a parent who can't sleep because they're worried their child's going to die, and the parent's anxiety, and sometimes parents are angry about what life has dealt them, not with their child, but with their complete change in their life as they saw it more moving forward. Their vision for their lives is completely altered by having a sick child. They can't go away where they want to. They can't do what they want. They can't go for a picnic sometimes because that will trigger the child's seizures. So that has flow-on effects to everyone, including the siblings. And I think we do need to develop much more supportive environments for everyone in the family and understand it, including siblings.
I was just going to say, listen, we have talked about a lot of things that need to be dealt with and considered when you're caring for a person with Dravet syndrome. And it's probably darn near impossible to do everything we said in a visit. But, you know, if you could take a little bit of time in any visit to just simply say to the family, is there anything, you know, you want to talk about before we end today's appointment, and make it a free response, about the family or about the non-seizure issues, just to make sure you've given them the opportunity. You may find out about a lot of things that trouble families much more than the seizures themselves in Dravet syndrome that you can help with.
It's incredibly important. And one of the things I've taken to doing in every consultation with every patient is saying, are you sleeping, or are they sleeping well, and are they happy? Because I don't think in children we're particularly good at depression, and in adults it's more sort of routine, to be honest. But I think in children we're not. But I couldn't agree more with Scott that you have to have open-ended questions, because that will then pop up whatever they're losing sleep about, which is often behaviour.
And I think that's what we know about the DEs in total is early in life, there's that very clear, it's all about the epilepsy, it's all about the seizure burden. But as the kid gets older, as the things evolve, it's generally sleep. It's generally the behavior, because actually the parents have become the expert at managing the seizure.
Exactly.
Thank you very much today to Professor Ingrid Scheffer and Dr. Scott Perry for joining me on Let's Talk About Dravet. It's really been great to find out that there is a similar appearance of Dravet and thought process about how to work with our families and advocate for our patients internationally. We know the challenges that our families face, and more importantly, our patients, and how we as clinicians have very similar thought processes across 3 different nations. I'm sure these are thought processes that are shared by clinicians throughout the world. So again, thank you very much to both of you for joining me today. Well, that's it for this episode. If you love this episode, please share it with your appropriate colleagues. The only way this podcast is going to get out there is by you lovely people sharing it. So I would appreciate it if you could. And if you want to stay with me and learn a little bit more about Dravet syndrome, then please join me on the next episode. For now, I'll say goodbye and see you next time.